Ladies and gentlemen, welcome to Clinical Journal Club for this week. Difficult program today. Here's the image out of the New England Journal this week. You can see it's a tongue, has a hole in it. It's a 34-year-old man who has HIV. He presents to an emergency department with headache, fever, and confusion. If we look at this lesion on his tongue, looks like it was a good idea that it was biopsied. And we can look at the histological section from this biopsy. He also has a chest x-ray done that we can't see, and he has bilateral infiltrates in both lungs. And if we look at this lesion, it looks like a bunch of round cell infiltrate here, and then there are these spherical things shown here, and these are spherules. They're typical for coccidiomycosis, and that's the correct diagnosis. Some fungi form spherules, and these are filled with spores that then make other fungi. If we learn that he also has bilateral pulmonary disease, he's immunosuppressed, he's probably from the San Joaquin Valley in California. At least sarcoidosis, tuberculosis, aspergillosis, and B-cell lymphoma don't make these structures. So that's the correct diagnosis. He also had lumbar puncture performed, which was certainly indicated, and looks like he has fungal organisms consistent with coccidioides spherules. So if we look at this disease, here's another histological section. This is again a typical spherule for coccidiomycosis. These things certainly result in granuloma formation. That's what's around this spherule. And here's an example of disseminated liver disease caused by coccidiomycosis with these multiple lesions that probably can be identified on liver biopsy. So these are granulomas. In these particular examples, they're non-caseating, as would be typical for tuberculosis, for instance. And in the examples that we saw, there is granuloma formation around the spherules. Here's a typical section of a B differentiation of B cells, depending upon whether or not we have a patient with mantle cell lymphoma or Burkitt's lymphoma or large B cell lymphoma, or what we're going to consider in a moment, chronic lymphocytic leukemia. And that's the first topic in the New England Journal. This is a leukemia of older adults. Starts going at about age 50, with then a steady increase to very old people. The patients generally have an enlarged spleen, as shown in this particular section, and on their peripheral smear we can see, in this case, fairly large lymphocytes. Sometimes there's a sea of smaller lymphocytes. In chronic lymphocytic leukemia, there are a whole variety of chromosomal aberrations and mutations that occur, and I've outlined some of them for you here. Some of these CLLs are fairly indolent and don't even require any treatment, but others are substantially more aggressive, depending upon their chromosomal and genetic profile that now is routinely determined. Now, in this particular study that we're going to look at, a key element is the Bruton'styrosine kinase, which is present here, which is present in B cells where it was first identified. Bruton was a pediatrician who first described an X-linked form of agammaglobulinemia. And as we now know, this disease is characterized by a mutation in the Bruton'styrosine kinase. Now, in some forms of B-cell lymphoma and in chronic lymphocytic leukemia, there are alterations in the Bruton'styrosine kinase that result in an increased activity. And we can now block the Bruton'styrosine kinase with Ibrutinib, which is a Bruton'styrosine kinase inhibitor. Another approach to this problem is dealing with BCL2. This is the B-cell lymphoma 2 protein. This is a complex protein. There are members of this protein family that actually promote apoptosis, whereas other members inhibit apoptosis. And we're dealing here with a BCL2 form that inhibits apoptosis. So we would like to block this BCL2 form so that cells that have BCL2 are driven into apoptosis. And there is a drug that does this. This drug is called Venetoclax, and it can inhibit the selective form of BCL2 that interferes with the development of apoptosis. And in this particular study, patients with older patients with a fairly aggressive form of chronic lymphocytic leukemia. This is not a randomized trial. All the patients that were eligible for this trial were treated with a combination of Bruton'styrosine kinase inhibitor Ibrutinib and a BCL2 inhibitor Venetoclax. And all the patients in this study received these two compounds. And what we're interested in here is how many of these patients enjoyed a complete remission, and in how many of these patients were bone marrow examinations indicative of a complete response. That means no more sign of leukemic tissue. So if we look at the patients, they have a mean age of 65. Men and women are both represented. And we can look at their lymphocyte counts, 75,000 as indicated here. Increase in serum beta-2 microglobulin was observed in some patients. They're anemic, and they have a variety of chromosomal aberrations and deletions that are typical for chronic lymphocytic leukemia. And if we look at the patients, they received 3 cycles, 6 cycles, 9 cycles, or 12 cycles of this combination chemotherapy. And as we can see here, after 12 cycles of this therapy, fairly substantial number of these patients enjoyed a complete remission and had undetectable minimal residual disease. And the responses were dependent upon how much treatment they received. And we can look at these responses as a function of age and men and women, and the various chromosomal aberrations that they exhibited here. And if you're particularly interested in this, you can look at these responses at your leisure on your own. But it looks like these are notable responses for a fairly aggressive non-indolent form of chronic lymphocytic leukemia. Were there adverse events? Yes, there were. And what we see here is the toxic effects of the therapy were noted in 60% of the patients. And it probably won't surprise us that neutropenia accounted for most of these effects. However, after 12 cycles of this combination chemotherapy, 88% of the patients that received it were in complete remission, and 2/3 of them had undetectable minimal residual disease in their bone marrow. So this is a favorable response. The next topic at the New England Journal, you can look at this particular X-ray here, where this is typical for multiple myeloma. And this is a plasma cell dyscrasia, as you know, and we can see examples of plasma cells with their large eccentric nuclei that resemble cartwheels, shown here. And these plasma cells produce myeloma proteins that are also responsible for these osteolytic responses that we see here. Now, the topic that concerns us here is a surface molecule that's also expressed in plasma cells. You'll recall that plasma cells don't express CD19 or CD20, so rituximab doesn't help, but they do express CD38. And CD38 is a surface molecule that catalyzes reactions of NAD, a nicotinamide adenine dinucleotide, and plasma cells express this particular protein. Now, there is an antibody that binds to this particular protein that we could use to perhaps target plasma cells that we can't get with rituximab, for instance. So what was done here, these are multiple myeloma patients who have just recently been diagnosed, and these are patients whose disease has progressed to the point that they're no longer eligible for autologous stem cell transplantation. And these patients are currently treated with lenalidomide and dexamethasone. And the idea here is that the patients would, in addition to those treatments, would benefit from receiving an antibody directed against the surface protein CD38. So those are the two groups, fairly large numbers of myeloma patients in both groups. We can look at their degree of performance status deprivation and whether it's IgG, IgA myeloma, or other types, and the randomization was successful. And what we can see here, this is progression-free survival, and this is almost over 3 years out, and we can see that the group that got the antibody against CD38, in addition to the other two treatments, did substantially better in terms of progression-free survival compared to the control group. And for various subgroups are shown here, the type of myeloma, their renal function at the beginning of treatment, ethnicity, male, female, etc. But it looks like all the groups basically profited from getting the antibody against CD38. There are side effects, and we can look at them here. This is a summary of response rates, and they're favorable in these various subgroups, I think even impressively so, but there are side effects that we can see here, shown in this table, and this group had a higher incidence of neutropenia. They also had more pneumonia, and that was statistically significant. So there are costs for inhibiting the plasma cells with the CD38 antibody. But on the whole, in this phase 3 trial, it looks like patients with newly diagnosed multiple myeloma who are ineligible for stem cell transplantation, that this antibody offers them a better perspective than the treatment with the two standard treatments alone. If you want to get into the New England Journal, it's helpful if you discover a new disease. And what the next topic in the New England Journal is a new tick-borne virus that was discovered in China. And this virus actually belongs to a family of flaviviruses. These are positive single-strand RNA viruses transmitted by ticks. And here's the picture of the happy first author. So what we see here, a new segmented virus that's associated with a febrile illness in China. And the index patient was found in Inner Mongolia. And from this index patient, the pathogen was derived and subjected to genome sequence analysis and electron microscopy. This information allowed the investigators to develop a reverse transcriptase PCR method to make the diagnosis. It also enabled them to perform cell culture analyses, and then with these tools to perform a routine surveillance of tick-borne diseases in China. And since the index patient was found in the town of Alongshan, this virus is now called Alongshan virus. And here are the areas in China that were involved where these patients were found. So what we can see here, these are cell culture experiments showing how the viral particles then proliferate and how they're expressed on the surface of these cells with immunofluorescence microscopy, what they look like on electron microscopy. We can then classify viruses. Since all known viruses have been sequenced, we can place these viruses in a clade analysis to show where they fit in with other flaviviruses. And the new virus here is shown in the red dot. And it's compared then to other viruses that cause disease, such as Japanese encephalitis virus and other tick-borne viruses. Now the patients, and as far as I could tell, there were no fatalities here, but the patients have headache, fever, fatigue, depression, some were in coma, And as far as I was able to discern, there is no specific treatment available for this particular viral illnesses at present. And here are the patients from whom this new virus was isolated. So this new virus has to be differentiated from other tick-borne encephalitis viruses, but with the sequence analyses that we've found here, identification of this virus in other parts of the world should surely be possible. The next topic in the New England Journal is an older topic. It concerns the treatment of aortic aneurysm. And as you're aware, aortic aneurysms can be treated with an endovascular prosthesis, as shown here, or the whole process can be treated operatively with the placement of a Y graft to bypass the aneurysm, allowing excision of this portion of the diseased aorta. Now, these two treatments have been compared in long trials, and this report concerns, in essence, the final report from the American Veterans Administration study, where large numbers of patients were randomized to these two forms of treatment. Now, as you can imagine, placing this large stent doesn't require for the patient to be completely anesthetized. Patients are out of the hospital more quickly, but the question is, which treatment offers the best long-term options for these patients? And in the VA study, 5,000 patients were assessed for eligibility. 881 subsequently underwent randomization to treatment with an open repair of the aneurysm compared to this endovascular stent treatment. And what we see here is that long-term survival was the same in both groups, and death or the requirement for a secondary procedure was also the same. This is a long follow-up on these old sick patients extending to 14 years after randomization. Most of the patients have already died, but they didn't die from ruptured aneurysm, as we're going to learn. They die for other reasons. And as a matter of fact, there were some ruptures. This was a rare event, and we can't apply conventional statistics to this, but there were 7 ruptures in the endovascular repair group and only 1 in the operative group. And the rupture in this operated patient wasn't in the abdomen. It was due to thoracic aneurysm, not related to the abdominal aortic aneurysm that the patient had on initial presentation. However, this is not a statistically significant result, and all of the other results here are not statistically significant either. Suicides, homicides. Suicides were more common in the endovascular repair group, but more of the patients in the open repair group were shot by adversaries, presumably. Now, if we look which treatment is better, we see here a balance between the two treatments. So we probably ought to go with the treatment that causes the least morbidity, and that probably is the endovascular repair. Why did these patients die? Now, they're all smokers, so they die of chronic lung disease, as was the case shown here, and this cause of death was also fairly common in the European trial. The next topic in the New England Journal is gastric bypass surgery for morbid obesity. Now, we've seen in earlier studies that patients that are subjected to this procedure have a fairly reasonable chance of having reversal of type 2 diabetes mellitus and also have an improvement in blood pressure. And this is also not a randomized controlled trial, but what we do in this study is we compare the results from adolescents. These are young people under the age of 17 compared to adults. And as you can imagine, surgeons are not that crazy about operating on adolescents, and the argument that's generally made is, let's wait till the patient is an adult, then he can make up his own mind whether he wants this procedure or not. But if we look at these two groups, there are some remarkable attributes here. These patients all have a body mass index of 50 before being operated on. That means that these patients have the size of two normal, already overweight human beings. And 5 years later, their body mass index in both groups has decreased from 50 to about 37 or 36. So these patients are not normalized, although they do lose weight. And they're here from 150 kilograms down to 111, 148 kilograms down to 108. So these patients are not cured from obesity, but they are made better. And here are various other parameters in these groups that you can inspect at your leisure. So if we look at weight loss, the adolescents are the blue people, the adults are the red people. Substantial weight loss, percent body weight decrease is substantial in both groups, which is extended out to 5 years. If we look at these data, then the adolescents had a greater chance of recovering from type 2 diabetes, over 80%, compared to the adults. Only 60% of them had remission of their type 2 diabetes. And the adolescents also had a remission of hypertension compared to the adults. So we might imagine that if we subject adolescents to this procedure, they could conceivably have some benefit because their chance of remitting from these other cardiovascular risk factors is better than is shown in the adults. And details are outlined in this particular table. The prevalence of diabetes was 14% among the adolescents and 31% amongst the adults. And if more of the adolescents recover from their diabetes, perhaps it's disingenuous to allow them to become adults where a third of them will have diabetes and they have less likelihood of having a remission, etc. So it looks like the adolescents actually did better than the adults, so probably there's no point in waiting. And the risk of death, intra-abdominal operations, cholecystectomy for gallbladder disease, etc., was similar in the two groups. So similar and durable weight loss, but not normalization of obesity, was observed in adolescents and in adults, and the adolescents had a greater chance of having a remission from their other problems. Now, last week we looked at this image from a patient with IgG4-related disease, and this week we learned that this patient had IgG4-related disease involving his pancreas, lacrimal, and parotid glands, and also had these coronary artery changes here, quite dramatic in this CT, but they didn't cause him any problem, and he was treated with low-dose aspirin. Here's another patient in the New England Journal. 84-year-old patient comes to an emergency room because he's short of breath. Well, okay, I guess I can imagine why, but he doesn't have chest pain. He has this electrocardiogram done, and we can see this marked ST segment elevation in lead 1 in AVL, and across the chest leads is shown here. Here's AVL and here's 1. So it looks like he has an ST segment elevation, myocardial infarction, but he doesn't have chest pain. Then someone takes a history, and he was recently discharged from another hospital where a similar electrocardiogram had been already observed, and a CT examination had been done. And what we see here is a very large tumor that's invading this patient's left ventricle that's responsible for this electrocardiogram. And this had been biopsied with a CT-guided needle biopsy indicating a non-small cell lung cancer. So the patient died. Now the review in the New England Journal reminds me of this paper from 1929 that was published in Berlin, and the author is Dr. Moses Swick. And Dr. Swick came to Berlin in the late 20s to do a fellowship in imaging. And what's shown in this, this is actually not the figure that was in his original paper, but what he did is he used uroselectan and was able to show that an intravenous urogram could be seen so that he could visualize the ureters and bladder and the kidneys in patients who were given this iodinated contrast agent. And Dr. Swick then returned to the United States, thank goodness in retrospect, and made a career as a radiologist and is known as the father of intravenous urography. Incidentally, in the issue of the Klinische Wochenschrift that included this paper, there's also the paper by Werner Forssmann showing the first cardiac catheterization. And these two techniques were then quickly combined to allow imaging in the vascular tree. Now, the review in the New England Journal concerns contrast-associated acute kidney injury. And this is a condition that was recognized in the 1950s, that patients who received iodinated contrast agents seem to have a propensity to develop acute renal failure. And since that time, additional iodinated contrast agents that have either low osmolality or are actually even isoosmolar have been developed in the hopes that these newer contrast agents would be better than uroselectan or diatrozoate, which we used for years. Now, this is a controversial topic, and the risk factors in patients that are sick that require angiography, coronary angiograms, having their aortic aneurysms fixed and what have you, seems to increase from year to year. And the nephrotoxicity is associated with diabetes. However, we know that diabetic patients are sicker all around, and if the effect of abnormal blood sugar or having diabetes mellitus is actually responsible for the increased risk, or just the fact that diabetes is a marker for people that are sick, is not so obvious. So there are several factors that could contribute to the risk here, including age of the patients, direct mechanisms of kidney injury from the contrast agents due to putative nephrotoxic effects on the tubular epithelium, loss of function, apoptosis, and necrosis. The hope was that isosmolar contrast agents would attenuate these putative actions. Whether or not they really are of lesser risk for causing this complication isn't entirely clear, but may be the case. Now, these contrast agents are said to lead to vasoconstriction, release of vasoactive substances such as endothelin, nitric oxide, prostaglandins, etc., that could result in decreased glomerular filtration rate. These are putative possible mechanisms that lead to increased risk of contrast agent associated nephrotoxicity. Now, we have clever guidelines committees that tell us what to do, and the European Society of Cardiology recommends intravenous isotonic saline infused at 1 to 1.5 milliliters per kilogram per hour for 12 hours before and up to 24 hours after the procedure. Although a randomized trial seemed to suggest that isotonic saline was of no value in protecting from iodinated contrast agent nephropathy. Then there have been a whole variety of strategies that have been tried comparing sodium bicarbonate to isotonic saline or nothing, or using acetylcysteine or etc. against placebo. And it's just not very convincing that there's any strategy that necessarily protects from iodinated contrast agent associated nephrotoxicity. And even the magnitude of the problem isn't clearly delineated, at least from the many randomized controlled trials that have been performed to assess this problem. So there's no evidence in my view, and also in this review, that acetylcysteine is helpful, that giving the patient statins before the procedure is helpful. There are perhaps other practical preventative considerations, and perhaps diuretics, ACE inhibitors, or ARBs should be suspended before treatment, although there are insufficient data to support this strategy, and actually we don't entirely know. I'm glad that Dr. Swick isn't around to have to deal with this problem, but at least we can stratify the patients on the basis of age and other comorbidities in terms of whether they have a high risk or a low risk. The clever guidelines people then recommend low osmolality or isosmolar contrast agents. Minimizing the dose is probably worthwhile, and people are still infusing isotonic sodium chloride, although I'm not convinced that that's helpful, but probably it gives the doctors something to do, and it makes at least the doctors feel better. Now, the patient in the New England Journal is a 44-year-old man who has joint pain, weight loss, and chest pain, and his disease starts in terms of joint pain, shoulder pain, that then spreads to arthralgias involving his fingers and knees, and pain medicines, etc., don't help. Then he develops anorexia, some problems with swallowing and epigastric pain. He has fatigue, febrile episodes, and we learn that he was born and raised in sub-Saharan Africa and had emigrated to New England 18 years earlier. And had not traveled outside of the United States. There was no knowledge of his having been exposed to tuberculosis, and he didn't have AIDS. So if we look at his chest x-ray, he's got cardiomegaly. Perhaps there are small pleural effusions bilaterally. A CT is done, and as we can see here, he has a fairly large pericardial effusion. So if we combine this symptomatic with these symptoms with pericardial effusion, it brings us closer to the diagnosis. And he's got some enlarged lymph nodes, and other imaging is done, and again, shoulder abduction was limited. Looks like sounds like he has lupus erythematosus. Even I thought of it. And if we look at this various lab work here, we can, these are fairly non-specific, modest differences on the reference range compared to his particular evaluation. But if we look at some details, if we can find C-reactive protein, marked signs of inflammation, LDH is also elevated. There are alterations in serum iron and iron binding capacity, although his ferritin level is markedly elevated. These are acute phase responses, suggesting a chronic inflammatory disease that involves his pericardium and his joints. And then some imaging is done here, although this condition could have probably been diagnosed with a sphygmomanometer and a stethoscope. But what we can see here is got evidence of compromised pericardial tamponade. So pericardial fluid was removed, and a gram stain didn't show any bacterial origin of this problem. And if we look at the differential diagnosis here of could this possibly be lupus erythematosus, he has some findings that are consistent with lupus erythematosus and other findings that are not. But then the appropriate testing is done, and we'll see that the testing was positive. So the discussant considers infectious disease, cancer, rheumatic disease, adult onset still disease, and then focuses on systemic lupus erythematosus. And his antibody tests, anti-double-strand DNA antibody tests, were both markedly positive. A lymph node biopsy specimen is done, which is also consistent with that diagnosis. And then the patient is then given the appropriate treatment and gets better. Now, if we move to the Lancet, the first paper that's in the Lancet involves ultra-short-term treatment of patients with iron deficiency anemia who undergo cardiac surgery. This study was performed in Zurich, and what was done here is patients who were scheduled for open heart surgery who had either anemia, or if they didn't have anemia, if they had low iron levels, they were eligible for this trial. They either got a cocktail of iron carboxymaltose and vitamin B12 and folic acid compared to a placebo infusion. And the hypothesis that was tested was that their blood counts might be better and they might require less transfusions post-operatively, even if this treatment was given perioperatively or immediately before the operation instead of several weeks before, as perhaps should have been done in their preliminary workup. So if we look at the patients that undergo heart surgery, most of them are men and they're older and they have a whole variety of cardiac problems, and most of them have coronary disease. And what we can see here is they're not all anemic, seem to be a little overweight here. Hemoglobin levels were actually a bit on the anemic size, 12.8 grams per deciliter compared to 12.9, when we would expect 14 ideally, and had some evidence of iron deficiency anemia as shown here, and their operations were similar in both groups. So it was a single-centered randomized trial, and patients with anemia or patients who had iron deficiency were randomized to these two treatments. And they got an intravenous infusion of 20 milligrams per kilogram ferric carboxymaltose, and they even got some erythropoietin, as we see here. They got vitamin B12 and folic acid. And indeed, they had higher hemoglobin levels fairly quickly, in my view, and they had a reticulocytosis. And that remained sustained through the first few days after operation. And their hemoglobin levels, not dramatically higher, but they are a little bit higher, and these reticulocyte counts were retained, and the amount of blood transfusions that they required was also diminished. Now, I love this next study, and it concerns quality improvement programs. And now we have expert committees recommending quality improvement for about everything that you can think of. And the surgeons are also subjected to this. And so committees of learned pundits and experts in evidence-based medicine develop quality initiatives that then the doctors are supposed to follow as they conduct care for their patients. And these courageous surgeons in the UK did a randomized trial to see if their quality improvement initiatives for surgeons make any difference. And they randomized patients that came to emergency rooms that required major abdominal surgery. And half the surgeons followed the quality improvement programs to the letter, and the other half of the surgeons did what they thought was right. And the patients were pretty sick, as we can see from their various scores that were shown here, Glasgow Coma score, and whether or not they had life-threatening illness and what have you. I was interested in the POSSUM score, so I had to Google it to find out how the POSSUM score works. And you can check out your own POSSUM score, whether or not you have underlying heart disease or lung disease and abnormal laboratory values. And the POSSUM scores in both groups were similar. So the patients in both groups were similarly sick. And what we see here is that there were no significant differences whatsoever. One thing is notable: the all-cause mortality in these two groups was 16% in both groups. And the expected mortality in patients as sick as these would have been 25%. So we can see here is that the surgeons that utilized the quality improvement program had no better results than the surgeons that just did what they knew was right. How do we interpret these data? So I didn't really know how to do this. We could interpret the results as indicating that the quality improvement programs are nonsense. But the discussant hones in on the fact that only 16% of the patients in both groups died, whereas 25% should have died. And it might be that the British surgeons are just so good that they don't need a quality improvement program for their results. The next topic in the Lancet involves oral immunotherapy for peanut allergy. And we've looked at papers in the New England Journal and even in Science indicating that young patients that have a risk of having an anaphylactic reaction can be orally desensitized so that they then will tolerate the peanut antigen. Now, in this particular study, the investigators asked the question, what's the implication for these findings for the general population? And if we subject all the patients with peanut allergy, can we expect them all to then be desensitized and that the whole population will do better? So what was done here is that every paper that's ever been written on this topic, whether or not oral desensitization actually helps the general population as compared to just some selected individuals, that was tested in this study. And there were 12 articles that were involved here, and the endpoints are epinephrine use, vomiting, gastrointestinal reactions, nasal congestion, shortness of breath, and these kinds of things. And what we see here is that actually the results do not favor oral immunotherapy, abbreviated as OIT, which implies that for the general population, this strategy may not be the best of all ideas, although individual patients could possibly be helped. That's how I interpreted this paper. If you're interested in this topic, I would suggest that you read this on your own, but the authors conclude that current oral immunotherapy regimens may achieve immunological desensitization, but they also result in a large increase in anaphylactic and other allergic reactions, which probably do not support the idea that these strategies should be generally applied. So I also pulled out the editorial that was written on this topic. So trading treatment-related side effects at home for allergic reactions to accidental exposure outside of the house might be a benefit for some patients, but certainly not for all, and further studies are going to have to address this issue. Here's a report from the Global Burden of Disease study, and I'm not an expert in this, I'm not an economist, but what was done here is, what do we spend on healthcare, and what are the implications for the rest of the world where societies are not blessed as ours is in terms of being wealthy? And we compare the way the world was in 1995, where rich countries, that's here and here, compared to poorer countries, how much they spent on healthcare. And as what we can see here is in 1995, sub-equatorial Africa and large portions of the Middle East and India and China were too poor to put much resources into healthcare. And other segments of the world had similar problems. But as we moved to 2016, far greater portions of the world, particularly now Russia and China, are spending a lot more money on healthcare, and that's also the case in Brazil and other parts of South America. And what's going to happen in the future? Well, countries are going to have to put, or it's projected that on the basis of the Global Burden of Disease study, that they're going to have to stick a lot more money into healthcare. And whether or not they can do this without being on the dole from rich countries remains to be seen. Because as we see here, healthcare spending per capita and gross domestic product are highly correlated with a bend in this relationship at about 10,000 and then a substantial incremental increase. And we can see here what's postulated for so-called developing countries and poor countries compared to the ones that are more blessed. So financing global health care has increased steadily in the past 2 decades and is likely to do so in the future. And of course, the review in the Lancet, which I didn't understand either, looks at so-called trickle-down innovation and the longevity of nations. And now we're talking about life expectancy. And the more money that people spend on healthcare, the longer the life expectancy is of populations. So the Japanese, the Germans, and the USA seem to be doing fairly well, but they're spending a lot of money for it, and societies that are not able or not willing to do so have less of a life expectancy. And we can see what's happened to countries over time in terms of their gross domestic product increasing and how much eventually they spend every year on healthcare. Here's a picture out of the Lancet. I didn't think this was so remarkable. I can't even see these, but it looks like it's a nice black lady who must have something wrong with her fingers, but I can see her peripheral smear. And what we see here are abnormally shaped erythrocytes, and of various sizes, and we can see multilobulated neutrophils. So she seems to have a macrocytic anemia. So this poor lady has probably has tropical sprue and vitamin B12 and folic acid deficiency. And the authors quite reasonably suggest that this not very sophisticated laboratory test might help us make these kinds of diagnoses, and then we can also understand what's wrong with their fingernails, which I can't really see in this image. Then I love this question in the New England Journal. This is marvelous. Bear with me, we're going to look at this just briefly. A 65-year-old man who smoked almost all his life has chronic obstructive lung disease without bronchospasm, but he has type 2 diabetes mellitus, okay? He has an aortic abdominal aneurysm, and we just saw this paper on how aortic abdominal aneurysms can be treated. He can't exercise because he apparently has osteoarthritis of his knee and chronic pain, and he sits in a wheelchair, and his electrocardiogram shows left bundle branch block, and his creatinine is 2.1. Apparently, they want to treat this aortic aneurysm. So we're asked, what should the next test be in this patient? Regadenoson stress test. I didn't know what regadenoson is, but I looked it up in Google, and it's actually adenosine. It's a new form of adenosine that was introduced after I retired, so I'd never heard of it. But the only advantage it has over adenosine is it has a longer mode of action. So you can treat the patients with a single bolus instead of a 4-minute infusion and enjoy a 100-fold increase in cost compared to adenosine. And then they want a myocardial perfusion study done. This is nuclear medicine. When I was a junior physician, we used to refer to that as unclear medicine because all the people ever said was, well, it could be, but we don't know for certain. Then you're also offered coronary angiogram. Then you're offered dobutamine stress test. Then you're offered exercise stress test. Well, he can't exercise because he's in a wheelchair, so I guess we can throw that out. And then the next option is no further testing before surgery. Now, one of the things that older physicians know is that a 65-year-old man who has an atherosclerotic aortic aneurysm is going to have coronary disease. 99.9% sure. So why do I need a further test? And if I do coronary angiography, he might get contrast-related acute renal failure. And these people want to subject him to elective aortic aneurysm repair. Well, they should have read the paper in the New England Journal this week where the endovascular treatment is associated with a lot of less morbidity and has the same end result 14 years later. So I would have picked no further testing before surgery, but that's not what the pundits say. The pundits say regadenoson stress test with myocardial perfusion. And I can tell you, we aren't given the results of the test, but I can tell you what the unclear medicine people are going to say. They're going to say that coronary artery disease cannot be ruled out. And then the next thing that'll happen is somebody's going to send this poor person to coronary angiography. So much for that. We're almost done, but I did want to briefly show you this because I love these interactive cases in the New England Journal. 29-year-old lady, looks like she isn't doing very well, has nausea, vomiting, and diarrhea. She has, we're told, systemic lupus erythematosus, similar to the patient that we just looked at in the New England Journal. And she gets rituximab and treatment for that. And so she comes in pretty sick and has lost weight and has fever, and we can see she's very unhappy. So here's her medical history: cutaneous lesions, and she's got renal disease, and somebody did a biopsy, and she, in essence, has rapidly progressive glomerulonephritis. At any rate, she has fibrocellular crescents in 40% of her glomeruli. So she gets these various treatments, has no known allergies, etc. So what happens next? We get a bunch of laboratory evaluation, and that's shown here. And we can look at her complement levels and her double-stranded DNA levels, antibodies, they're high, and these various things. She doesn't have Clostridium difficile. And if we look at these laboratory values here, her glucose levels are high, and her creatinine is still within the normal range despite 40% crescents, and so we're happy about that. Then we're asked to figure out why this woman has diarrhea. And on the basis of what we've learned from this laboratory testing. So what can we learn from this? Which of the following options is most likely cause of this patient's diarrhea? And the cause would be, the most common pathogen would be Clostridium difficile. And however, we didn't see that. So the patient, we're shown, patient presents to an urgent care clinic, 3-day history of abdominal pain, malar rash, laboratory tests, has lupus erythematosus. We're shown this CT, and what we see here, these are in essence called target lesions, and they suggest that there's markedly increased inflammation of the small bowel wall in these cross sections that we can see here. So which of the following options are the most likely cause of this patient's diarrhea? And if she has this complication, we'll pick a complication of lupus erythematosus that the vasculitis could possibly cause these changes that we see in the CT. Then this patient, we're also aware of, it's also possible that mycophenolate mofetil might possibly cause diarrhea, but then she could also have an opportunistic infection with some sort of a virus, so we can pick that answer. But it's also possible that she has a side effect from mycophenolate mofetil, which can also cause diarrhea. So we have to work that up. Then what we find out is this patient suddenly lapses, while in the hospital presumably, lapses into coma. So they call a neurologist that looks at her, and he moves her head around to see if she has any signs of meningitis. So he looks for Brudzinski's sign and Koenig's sign, and these the neurological examination was notable for neck stiffness, so she has a Brudzinski sign, but Koenig's sign was negative. Well, this patient needs a lumbar puncture. And then we're asked, should she have CT before the lumbar puncture? And I would have said, I don't think so, but we learned that the guidelines experts suggest that a CT be performed in patients that are immunosuppressed. So we can do a CT. Nowadays, that isn't an issue, and you can probably get one in 20 minutes. Then we look at the results of her lumbar puncture. And she's got 94 white cells, and most of them are lymphocytes and monocytes, so that it doesn't look like bacterial or fungal meningitis. So it looks more like she has viral meningitis. Then we look at the differences in patterns of lumbar fluid depending upon whether or not you have viral meningitis, tuberculous meningitis, fungal meningitis, or a subarachnoid hemorrhage. And so we can look at the relationships between opening pressure, white cell count, red cell count, protein level, and glucose levels in the cerebrospinal fluid in these various conditions. So these things are fun to look at, and you should know these things by now. So in addition, a CSF analysis is done that's consistent with viral encephalitis. And why should this patient have viral encephalitis while in the hospital? And it turns out that her PCR testing for West Nile virus, which is fairly endemic on the east coast of the United States, was positive. And so you can look at this map where these things are the average incidence. This is a fairly common problem in the United States. I'm not so aware that this is this common in Europe. So what should you do? And since there's no treatment for West Nile virus, probably the best decision is to do nothing. And that's the correct answer. She gets better and goes home. So thank you very much for your attention, and join me next week, and we'll see what's happened since then. That's it.